Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome AAOMPT listeners. This is Kevin MacPherson, and today we are continuing our interviews of our various presenters from the 2020 Virtual AAOMPT Conference. Today I am in luck to be able to interview Emily Slaven. Dr. Slaven presented on the subject of Are We at the Table? Maximizing Collaborations to Impact the Care of Those with Arthritis. Now, before we get into our interview on her presentation, let's give you a brief background on Emily. So Emily completed her bachelor's degree in physiotherapy from University College Dublin and a subsequent master's degree in physiotherapy from Manchester University. From there, she jumped over to the United States and completed a master's degree in biomechanics, as well as a PhD in physical therapy. She also underwent fellowship training with Duke Hospital and was recognized as a fellow of the American Academy of Orthopedic Manual Physical Therapists in 2011, which happens to also be the year that I achieved my fellowship status. Since then, Emily has become a full-time associate professor in the orthopedic curriculum for the Doctor of Physical Therapy program at Krannert School of Physical Therapy, which is housed in the University of Indianapolis. Dr. Slaven also maintains an active clinical practice and is the president of the Indiana chapter of the APTA. In addition to all of this, Dr. Slaven is the chair of the board of directors for the Indiana Arthritis Foundation, which is part of the reason, I'm assuming, why she brought the talk that she did to our virtual conference. Now, having said all of that, Emily, tell us how you're doing today.
Good afternoon, Kevin. I am doing really well. Great day. Started with a run with my dog, as I typically do, and just appreciate the ability to be up and active and being healthy on a day like today.
What a wonderful response, and one that I would expect from somebody who does enjoy looking at the evidence and the research behind arthritis and staying active. Unfortunately, I'm in Florida right now, and we have a tropical storm bearing down on us, so I probably won't be able to walk my dog for at least 24 hours, at least not more than under the eaves of our house. Now, enough about that. Emily, do you mind just giving us a brief overview of your talk?
Sure. Yeah, absolutely, Kevin. So as you mentioned, the driving force behind coming to the AAOMPT conference committee and my presentation that I gave relates to our role of working with those individuals who have different forms of arthritis. I've been involved for many years with the Arthritis Foundation, and earlier this year in 2020 was fortunate to attend the National Board of Directors meeting in Atlanta, Georgia, with the Arthritis Foundation. And that's where we talked a lot about what they call the Insight Survey. And that's really sort of the crux of my presentation that I gave at the AAOMPT virtual conference, was bringing to our membership and to physical therapists in general, just knowledge about what the challenges are faced by those with different forms of arthritis.
Now, what were some of the key findings that you pulled out, or the key statements that came out of your review of the research that was gained from those surveys?
So there's a number of elements. One of them related to pain and the presence of pain. When those were for those individuals with a variety of forms of arthritis were interviewed and participated in the survey, 100% of those who responded, and that was about 18,000 total assessments have been collected so far for the data that we looked at, we found that 100% of those reported pain over the last 7 days with an average pain score of 5 to 10 on a 10-point scale. That was of interest, but as a physical therapist, what was of particular interest was the challenges that individuals had with the ability to walk. 43% reported that they could not walk at all or had major difficulty walking at least 15 minutes a day in the past 7 days. So that really jumped out to me as a physical therapist, and particularly as a physical therapist and researcher who looks at the mechanics of the impact of osteoarthritis on hip and knee motion and the ability to walk.
So not really unexpected to see that there's difficulties with walking, but that level of walking was kind of like, that was a little bit, I was taken aback by that. I didn't think it would be that big of a percentage of individuals who reported that much interference with their day-to-day activities. Now, they also, if I recall, you also had some numbers looking at sleeping, working, and family activities. What did the results pan out for those different activities?
When it came to sleeping, less than a third of them reported that they slept well, and 73% of individuals reported that they felt fatigued over the past 7 days. So that definitely had an impact on their physical ability during the daytime. When it came to family activities and participation, 67% reported having difficulty doing all the family activities that they wanted to do.
So we basically have somebody who is having issues with just getting around, having issues with really recovering from the day. If we argue that that is one of the main functions of sleep, as well as other different things that occur there, and interacting in life with those different participation level activities, if we go by the International Classification of Function. Now, was there any data collected with regards to, say, depression, anxiety, fear?
Yes, the survey also had an element, there was kind of a tenement that looked at sort of psychological factors. Much of the development of this research tool, this survey, came from previous surveys that the Arthritis Foundation had done over a series of years. And they established that the psychological impact was an important element to capture. And they found in this particular insight survey that 2/3 of those surveyed actually said they felt depressed during the past 7 days, and 2/3 said that they felt anxiety or fear related to their health and well-being.
So again, a global picture. We've definitely got elements of psychosocial. Now, if we get into the biological component, and this came up with a slide earlier in your presentation. So I'll go back to my bias as a orthopedic manual therapist. When I hear arthritis, I hear predominantly osteoarthritis. But you mentioned in one of the slides that this definition of arthritis, or you provided a definition of arthritis, and then you gave a list of a lot of different variants of arthritis. Do you mind just giving us that definition and maybe a couple of different types of arthritis that the average clinician might not think of?
According to the CDC, the definition of arthritis reflects inflammation or swelling of one or more joints. And it describes really, the CDC described 100 or more conditions that affect the joints, tissues around the joints, and other connective tissues relative to that joint. And the specific symptoms vary depending on the type of arthritis, but typically patients will report joint pain and stiffness. But the ones that kind of stand out to me, certainly, as the forms of arthritis that I consider when I think of sort of the rheumatology aspect, are definitely ankylosing spondylitis, osteoarthritis, as we've already mentioned, rheumatoid arthritis, systemic juvenile idiopathic arthritis, SLE, and those are probably the key ones that come out, along with a lot of other connective tissue disorders.
So in that, we have several different variants that do have genetic components. They do have really recognized physiological components to their clinical presentation. One of the bits of, or one of the conundrums, I guess, that physical therapists can run into specifically with osteoarthritis is that somewhat disconnection between the pathoanatomy and the person's complaints. They might have a lower level arthritis based off of KG reading, or the Lawrence Kellgren scale, or
Hmm.
they might have a high amount, but that doesn't really necessarily match the amount of pain they may or may not have. What is the balance between being given the diagnosis of arthritis with that need for the swelling and the symptoms versus having what would be maybe subclinical arthritis?
Sure. So that brings up a great topic, and certainly it's been discussed frequently now that what is visualized on an image, whether it be a plain film radiograph or more involved imaging, is that there's fairly poor correlation between the severity of the disease and the symptoms that the patient experiences, particularly pain. And we definitely has caused the thought process about what truly is creating the pain. If it's not a direct correlation or relationship to the degeneration, what else might be going on? And my understanding is that there's much more of a nociceptive change that's associated with osteoarthritis, particularly peripheral sensitivity. And that's more of where the research is looking at. Certainly with patients, my experience is that patients will come in and tell me some days that they're feeling really good and some days they're having a really rough day. And I personally know that there's no way that their cartilage loss of cartilage has fluctuated between 2 days. So there must be more involved than just simply looking at the imaging and making a decision based on their symptoms based on what you're seeing on an image.
It definitely still sounds like there's much more to learn from a causative angle or from
Hmm.
a mechanistic type of angle and looking more at maybe the genetic components or at least the molecular components of it.
Hmm.
Which actually brings me to another observation I had. At one point, you pulled up an image that provided some detail on the percentage per population of individuals who had arthritis in different states. And
Hmm.
it was noticeable that the southern states had a higher prevalence, if that is the term I want to go with. One of the things that you mentioned was, well, there's a potential that we have snowbirds coming down from the north and moving down there. But one of the things that I teach at the University of Florida is some of the nutrition aspects or looking at some of the cardio, respiratory or cardiovascular fitness prescription. And I saw really a similar map to the obesity map. So my question is, when we look at some of the ongoing beliefs of weight associated to arthritis and obesity associated to arthritis, and even if you wanted to limit that to knee, joint, or whatnot, is it simply a matter of like we just need to get these people to lose weight, or do you think there's something more complex going on than wear and tear issue?
Yeah, that's a great question. And there has been a lot looked at this whole concept of metabolic syndrome associated osteoarthritis. You make the point about the larger mass, which implies or creates a heavier load on the joint, which certainly is a factor, which is sort of the first thing we think about. But there's also been found that there's a low grade inflammation that goes on, and the actual increase in the amount of adipose tissue that's present in an individual who's obese, because that adipose tissue is a source of, cytokinase, chemokinase, and metabolically active mediators, and particularly the adipokinase. And so these are factors which create an additional inflammatory reaction, which then impacts the joint.
So it goes again to that complexity, and we're learning so much more about that complexity. Now, arguably, we do know that exercise has been shown to be beneficial for most types of arthritis, and we know that exercise is also beneficial for obesity in addition to some of the nutritional changes. So one of the other aspects that came out was the ACR's recommendation for exercise, but there was a statement that said we really don't have the ideal prescription for exercise. Do you feel that the prescription is going to end up being a very simple research endeavor, or do you think that's going to be a very complex endeavor?
I really feel it's going to be complex because when it comes to exercise, it is so unique, and what appeals to one individual as regards to what they're willing to do based on any symptoms that they have, it's very hard to say that every individual who has osteoarthritis of the knee needs to go to the pool and do X number of minutes a week of exercise at a certain intensity, because not all individuals will have the ability to partake in that kind of activity, or to desire perhaps. So I think it's not one single exercise, nor one simple dosage package that's going to give us an answer. And I think that that's the challenge is pinning down a moving target when it comes to establishing. And one of the elements I believe I shared from the American College of Radiology when it came to exercise was the importance of giving those with arthritis very individualized information and guidance. And I think that that's important in our role as physical therapists, in that we do have the training and knowledge and interest in working with these individuals to provide them that information that's unique. Now, that makes it hard because now I'm talking about a lot of, heterogeneity, and not sort of one perfect sort of study where everybody does exactly the same thing. So I think that is would be helpful to have some guidance, but we need to have a wide variance of opportunities for exercise, and options for individuals. So a lot of what we do obviously is more pragmatic with our individual patients and their needs. But is there a need for more detailed research studies that help kind of bring together that detail, as to dosage, intensity? That would be helpful to guide physical therapists and physical therapist assistants in the prescription that we give.
So I hear two things coming out of that response. One is, for lack of a better term, personalized medicine, or in this case, personalized physical therapy prescription. The other thing I hear out of that is big data. We need to also be able to look at big data from that. One of the thought processes that I've seen applied more to the chronic pain population and being applied to just the obese population in an endeavor to lose weight has been the use of wearables. So looking at things like Apple Watches, Garmin watches, using Apple Health to track data, using Google Health to track data. Do you see a role that the foundation is looking to fill or utilize to gather more information using some of these newer technologies?
I'm not aware currently of any initiative that the foundation has. I'm more involved with the local market, but that would be a very interesting element to explore. Some of the challenges would be obviously accessibility to this type of a wearable. Many individuals who have arthritis may not have the medical funding to be able to do this. I know that there are some research groups, and particularly joint replacement prosthetic companies, who are looking at the element of providing a patient, after total joint replacement surgery, with a wearable to be the physical therapist, which brings into itself some interesting questions and sort of debate about whether that truly replaces the element of an in-person care. But if it goes back to in general with individuals and their ability to perhaps have a little bit more motivation to be active, I see the value and potential for it. But at this time, I am not aware of any initiatives that the foundation has in this direction.
That's an interesting response. The beginning of it, and definitely as you continue through it, makes me think more and more about health disparity. And without diving too far into that, I kind of frown on my own question, since I've been one of the voices around our university looking at our transition from our pro bono clinic to a pure telehealth model, knowing that our mission was to help underserved, and knowing that those individuals oftentimes will not have access to the high-speed internet required for telehealth. So it's definitely a complex issue in general. So when I look at that data map, if we go back to the data map where it shows a large proportion of individuals in the South suffering from arthritis comparatively to, say, the northern states, we saw that the data collection from the Insight survey came from areas like the Northeast, or at least it was a little bit heavier in the skew towards that direction. What do you think is limiting us from getting some of the information from those southern states? Do you think that might be health disparity issues? Is that some other factor that I'm not even considering?
I definitely think it could be a health disparity issue that's going on. It may also just be simply the knowledge of providers. You know, a lot of rheumatologists who provide information, for example, to the CDC, when we look at the numbers for those with arthritis across the United States, you know, the numbers that I presented were physician diagnosed rates of arthritis. And we look at the insight survey, and that very much is dependent on, for example, rheumatologists and other healthcare professionals sharing with patients about the importance of completing such a survey. Now, some markets are stronger as regards to having a larger presence of the Arthritis Foundation where they've been able to get out and share that, the importance of completing the insights survey. But definitely there's a lot of work to be done in amassing more than just the 18,000 surveys that have been taken so far.
Especially when we consider the millions of individuals who suffer from the various diagnoses that fall underneath that arthritis category or definition, which we are hopeful that our listeners through the show notes will be able to follow some of the links and be able to help Emily out with gathering more and more information from providers, but also from the patients themselves.
Absolutely, yeah. It's very much upon us and other healthcare providers to encourage those with arthritis to fill out the survey so that they can have access to longitudinal data that helps not only the Arthritis Foundation, but also it helps themselves because they can keep track of the progress of their condition.
So now coming a little bit more back to home base with the AOMPT crowd, there was a side discussion that occurred in your presentation. It was looking how the different recommendations from the American College of Rheumatology as well as EULAR, which I'll allow you to give me the expanded acronym because I'm forgetting it right now. They don't recommend manual therapy. But do you feel that that is related to simply the research body for manual therapy, or do you feel that it may be a result of the different variants of arthritis, or is there something else that I'm not even considering?
Sure. Great question, Kevin, and one that I really thought a lot about as I prepared my presentation because I spent some time looking at the research and just to firstly answer your question regarding the EULAR acronym, and that is the European League Against Rheumatism, and again goes by the acronym of EULAR. And that's really the voice for much of Europe related to arthritis, just like we have the American College of Rheumatology here in the United States. So, when it comes to considering why they didn't feel manual therapy was a key factor or an important factor, um, you know, I tend to, and as I looked at these individuals, for example, the authors, I didn't see any names on the Euler study. I didn't see any prominent physical therapy individuals, and the same really with the American College of Rheumatology. So, firstly, I think about potentially who brought the data together as regards to the studies. Perhaps there wasn't such a focus to look in depth at what physical therapists were doing or to be, to expand the reach of the studies. I also feel there's been a little bit of shift, back 5 or 10 years ago. There was quite a few studies coming out of countries with socialized medicine. So, say, for example, New Zealand, Australia, the United Kingdom, where I feel, and it was my own personal experience, both in my education but also in my practice, that the use of physical therapy or physiotherapy was much more widely around than I see here in the United States. And part of the challenge in some of the countries who have socialized medicine is that it wasn't a readily available thing to go have your knee or hip replaced. Here in the United States, I know at least in Indiana and Indianapolis, if you decide on Monday, I want to have my hip replaced, it's a pretty good, as long as Medicare doesn't have any tie-ups if you're Medicare eligible. But you could technically have your knee or joint replaced, that same week. Whereas in a lot of other countries, there is a time lag between maybe having a diagnosis and then having a surgical procedure performed. And in these countries, a lot of times, particularly the work of folks like like Huxley Abbott and his colleagues, Kim Bonnell, they've been very fortunate to work with large data sets of individuals who have a variety of forms of arthritis and looking at the impact of manual therapy and exercise. So it's definitely in the past there have been some studies, but the volume of these studies has sort of settled off in the last 3 to 5 years. So I'm not seeing as many of these studies coming out of these countries. So it is interesting as to why they're changing perhaps the volume of the research. But certainly 10 years ago there was a lot of support for manual therapy. So I wouldn't put totally the blame on the Euler report or the American College of Rheumatology, because I don't perhaps see as much research coming forward as I would have done 5 to 10 years ago.
So you make mention of maybe not having a seat at the table for some of these recommendations. Do
Mm-hmm.
you feel that things like or us being more participatory in the Arthritis Foundation's insight surveys, do you feel like that's a mechanism that will help physical therapists get to the table with the different providers in an interprofessional manner?
I really do. At the meeting I was at in January, we had a lot of opportunity to network with others who had been invited to that meeting, others in addition to the board of directors. And I would sit at tables with rheumatologists, pediatric rheumatologists, primary care physicians, and advanced nurse practitioners, social workers. And that was a way to really have a very intercollegial conversation about how best to care for those with arthritis. And that was a unique opportunity that I really embraced, because I felt, wow, here's a chance for me to share and talk about the value of physical therapy, and whether it be from the aspect of exercise or manual therapy or education. One of the things that's so paramount to what we do. And very often you don't get those opportunities to sit down and have a really good chat with another healthcare provider, and so you can share about the value of what we can do to provide guidance and management of these patients.
Well, Emily, we definitely appreciate you sitting in that role in providing a voice for our profession, but also providing a model for other physical therapists to bring our profession's voice to the table with regards to arthritis. So, Emily, as we start to come to a close on the interview, what's really been a good interview, what might be some other projects that you're currently working on, or expansions of this project that you're currently working on, that our listeners should be on the watch for?
Kevin, a lot of the work I do currently is in our movement science lab at the University of Indianapolis, and two current projects that we've had ongoing that have been a little sidelined with COVID relate to establishing what the impact is of manual therapy on both the hip joint and the ankle joint. And we've been teasing out the impact of a thrust manipulation both on the hip and the ankle, and establishing whether with this application of manual therapy we create any changes in joint range of motion. Do we change the way an individual is able to load the limb, or do we affect the processing system when it comes to pain? Can we change that with our hands-on approach? So that's kind of been an area of interest, and had been hoping, had submitted an abstract to attend and present at IFOMP this year, unfortunately with the changes there, but hope to continue this research that I've been doing, and that was under a grant through OTPT, and looking to present that hopefully in 2022.
I'm personally very much looking forward to seeing the outcomes of those. Being exposed to Carol Courtney and some of her work looking at changes in pain with regards to compression or distraction of the knee joint. I had a very early exposure of what manual therapy might be doing on a perception or a pain system level. I also have worked with a orthopedic physician who was known for doing hip scopes, and I described thrust manipulations to the hip, and he basically said, well, that's a waste of time. It's too deep of a hit of a joint for you to really do anything without having sophisticated surgical equipment. And then I proceeded to perform one of these on him, and he gained quite a bit of range of motion. So at least anecdotally, I would love to have a little bit higher level research than what I've currently been using for why I treat the hip. Now, that being said, Emily, what's the best way that some of our more interested listeners might have for reaching you if they have any additional questions?
Sure. Probably my email is the best way, Kevin, and that's my last name, Slaven, at uindy.edu, or at my Twitter handle of at Emily Slaven Either one will get a hold of me.
Well, thank you very much, Dr. Emily Slaven, for all of the efforts you put into this presentation and all of the efforts you put into helping our profession get that seat at the table. I hope you have a wonderful rest of your day.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal health care or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.